Hi, welcome to this lecture on connective tissue disease ILDs, and I'd like to thank ICS and Simpler for asking me or giving me the opportunity to do this talk. So connective tissue diseases are a heterogeneous group of systemic inflammatory disorders, and they encompass these entities: RA, scleroderma, Sjogren, SLE, PMDM and antisynthetase, and mixed connective tissue disease. IPAF is an entity that was created essentially for research purposes, and I'll spend about a minute on that later on. The connective tissue diseases can involve all of these structures in the chest, but today we will be focusing only on the lungs. We will talk about the protocol for scanning, which I have discussed before, different patterns of CTD-ILD, CT signs suggesting underlying ILD, the individual connective tissue diseases, and as I said, a couple of minutes on IPAF. The protocol for scanning, a good quality study is an absolute must if we want to make a good diagnosis. This is the protocol: volume inspiratory 1 millimeter scans, expiratory scans, and volume prone 1 millimeter scans. The different patterns that we can see are listed here. The UIP pattern consists of subpleural basal predominance of honeycombing and traction bronchiectasis with nothing else. And so this is a common pattern seen in multiple connective tissue diseases. This patient has scleroderma and also has esophageal dilatation. Then we have the NSIP pattern, where we often get subpleural sparing, spatial and temporal homogeneity, and absence of honeycombing. You may get traction bronchiectasis. There can be a cellular and a fibrotic component, and I discussed NSIP in detail in the last lecture in March. The third pattern is the organizing pneumonia pattern, where we get subpleural or peribronchovascular areas of consolidation and admixed ground glass. We've seen this pattern commonly during COVID, but it also occurs with connective tissue diseases, as in this patient with RA. Here's another patient who has a fibrotic OP pattern, peribronchovascular areas, but with traction bronchiectasis, seen in this patient with mixed connective tissue disease. Then we have cystic disease, where we see perivascular cysts as part of Sjogren's disease. Lymphocytic or lymphoid interstitial pneumonia also has perivascular cysts. But remember that this is not an interstitial lung disease until you see an ILD. So these are just the perivascular cysts of Sjogren's. And if you see an associated ILD, then that becomes LIP. Now, all this is fine, but when do we suspect an underlying connective tissue disease? When we are seeing CT scans of interstitial lung disease? And that's important because not all patients present initially with full-blown CTD features, and so we actually suggest on the CT that the patient may have CTD, and then further tests are carried out to confirm the diagnosis or not. And here are all of those signs that I'll be talking about. Exuberant honeycombing is when we have more than 70% of a specific lobe involved with honeycombing. So you're seeing subpleural basal predominant and lots of honeycombing and cystic change in this patient with RA UIP. So when you see this, you should suspect connective tissue disease. The second is heterogeneous lung destruction. So along with the honeycombing, there's extensive cystic change involving the lung parenchyma, usually bilaterally. In this case, it's the left lower lobe. And this is described in patients usually of RA and SLE, but may be seen with any connective tissue disease. The anterior upper lobe sign is exuberant honeycombing in the non-dependent upper lobes or in the anterior segments of the upper lobes. Now, this sign, if seen, is a very specific sign of connective tissue disease. You rarely get it with any other condition. And this patient has rheumatoid arthritis, but we commonly see it with scleroderma and SLE as well. Another recently described sign is island-like fibrosis, where the intervening lung parenchyma is normal, but we get these wedge-shaped areas of honeycombing, traction bronchiectasis, and reticular opacities. These typically occur in the CTDs that are also vasculopathies and so are commonly seen with SLE and scleroderma. The four corners sign is typically seen when we have islands of fibrosis occurring in the four corners, so anterosuperior and posterior-superior. And this is better appreciated, therefore, on the sagittal and the coronal images. And you can see that the intervening lung is quite normal, and this patient has scleroderma. The sign we use every day in practice is the straight edge sign, which is seen on the coronal and the sagittal images, where there's a very sharp demarcation between the abnormal and the normal lung. And when we see this sharp demarcation, it gives us a sense that the patient may have connective tissue disease. So every patient who comes with CTD, we look at the images in sagittal and coronal at the same time. And if we see a straight edge, then I will write down that please aggressively rule out connective tissue disease. And see this patient with UIP, IPF, there's an undulating margin as against a patient with CTD-ILD who has a straight edge here. The last sign is low attenuation areas. This is specific for scleroderma. You see this patient has a fibrotic NSIP pattern. We have subpleural sparing here. Now, within these reticular opacities, you see these low attenuation areas. This is supposed to again represent a vasculopathy. You might probably see it in SLE as well, where it is described as a sign of scleroderma. So these are all the different signs that when we see on a CT scan suggest an underlying connective tissue disease. Then let's look at the individual CTD. So we have RA, where UIP is more common than NSIP, which has the same commonality or incidence as OP. And these are more common than LIP. So I'm just going to show this for the rest, and I will not really describe this. Smoking increases the incidence of RA-ILD and is an adverse prognostic factor. And if you have UIP and extensive disease, then that's adverse prognosis. So here's a patient with RA, smoker. You can see centrilobular emphysema, paraseptal emphysema with a probable UIP pattern. And this is very classic CPFE in a patient with RA. This I had already shown. You have an anterior upper lobe sign with exuberant honeycombing in the non-dependent segments. And here is a patient with exuberant honeycombing and heterogeneous lung destruction in this patient known to have RA. This is a patient with RA presenting with an organizing pneumonia pattern. And this patient has RA with lymphoid interstitial pneumonia, with perivascular cysts, ground glass, reticular opacities, and a mix of multiple findings that suggest this pattern. In RA, we can get other findings. We can get airway diseases, follicular bronchiolitis, necrobiotic nodules, and drug-related complications. This is a patient who has of RA with extensive peribronchial thickening, distal branching, centrilobular opacities, and nodules. And this suggests follicular bronchiolitis. This is a patient of RA who has these necrotic lung nodules, which I biopsied, and this was consistent with necrobiotic nodules. We then come to scleroderma, where NSIP is commoner than UIP. If you have UIP, that's a worse prognosis. PH is a common accompaniment and also has a worse prognosis. You do try and differentiate cellular from fibrotic NSIP, though it is not always possible except retrospectively on follow-up. And you may see esophageal dilatation as well. So this is a very early scleroderma ILD where we see just subtle reticular opacities, but which are confirmed to be real on prone images. This is more advanced disease where we see subpleural sparing and spatial and temporal homogeneity. So there is an NSIP pattern, but you see these peribronchovascular lesions that also suggest an associated organizing pneumonia pattern. And very often in these patients, we see mixed patterns. So you have a mixed NSIP OP pattern here. I'd already shown this scleroderma with the UIP pattern. And in scleroderma, follow-up happens very commonly at 1 year or 2 year intervals. And here is a patient who has improved 13 months apart, and here is a patient who has worsened 15 months apart. We also see complications in these patients, and here is a patient who developed tuberculosis in the left apex, which then regressed 4 years later, while the NSIP pattern remained unchanged over those 4 years. SLE is a more wet disease where we get pleural and pericardial effusion, lupus pneumonias, NSIP is more common, but we can also get diffuse alveolar damage. So here is a patient with acute SLE, pericardial and pleural effusion, and you get these areas of consolidation showing an organizing pneumonia pattern but are consistent with lupus pneumonia. And here you can see that the patient just has these subtle areas of ground glass representing lupus pneumonitis in another patient. This patient over 14 years has shown a UIP-like pattern, but what you're predominantly seeing is traction bronchiectasis with extensive cystic change and heterogeneous lung destruction. Whereas here is a 50-year-old with NSIP who shows a classic NSIP pattern. You have non-dependent involvement here with reticular opacities and traction bronchiectasis. This patient also has heterogeneous lung destruction. I showed this image earlier as well. And here you have island-like fibrosis because SLE is a vasculopathy, and you can see these focal areas, likely because of focal infarction and vascular changes causing these areas of fibrosis. Patients with SLE can present with diffuse alveolar damage, and here we see diffuse alveolar hemorrhage with extensive areas of ground glass, septal thickening, almost a crazy paving pattern with bilateral pleural effusions and dropping hemoglobin. Here's another patient with extensive lung disease, and this would just qualify as acute lung injury. We then have Sjogren's syndrome, where it's more common in women as compared to men. You can have primary and secondary Sjogren's. NSIP is common, though LIP is considered a typical ILD of Sjogren's. NSIP is still the commoner entity, and you can also get airway diseases with a significant increased risk of lymphoma. So here is a classic Sjogren's NSIP. We have spatial temporal homogeneity, traction bronchiectasis, no honeycombing. And this I'd shown earlier where we're seeing perivascular cysts of Sjogren's disease, but there is no LIP at this point in time. This is another patient who presented with an organizing pneumonia pattern in 21. Actually had biopsied this as well. There was progression over 3 years. At this point, I thought perhaps the patient had an invasive mucinous adenocarcinoma. Turned out to be an OP pattern. Then the patient turned out to have Sjogren's. And then when the patient was put on steroids, you can see significant improvement on the radiographs. PMDM and the antisynthetase syndromes present with different forms of ILD. NSIP is the commonest. They also have aspiration syndromes. And these are two different patients, both of whom show typical NSIP patterns. Here you have a patient with antisynthetase syndrome who shows this proximal traction bronchiectasis in the middle lobe, which is not just common for antisynthetase, but occurs again with connective tissue diseases. And here we see traction bronchiectasis without honeycombing, telling us that this is a fibrotic NSIP pattern. We have mixed connective tissue disease. Again, women are more involved, or occurs more in women than men. And you see the rest of the findings here. This was a proven mixed connective tissue disease, has a fibrosing, organizing pneumonia pattern. And another patient with MCTD who has an NSIP pattern here, which has improved over a year. So to summarize, these are the 6 conditions, and these are the different patterns that we get here. And we should be aware of what is common in which connective tissue disease. So if you have a patient known to have scleroderma or Sjogren's or SLEs, you will look for those patterns. But if you have a patient presenting as an unknown, then we would suspect CTD based on the signs that I mentioned earlier, and then try and figure out perhaps which CTD this might be. IPAF is a very confusing term. It was created so that everybody who does research on CTD-ILDs would use the same uh, criteria to identify those patients. And it was assumed that people would work together. What has happened is that while at the research level, this is to some extent happening, it is somehow being used as a clinical term, which was never the intention in the first place. So today, the idea in the last about 16, 17 minutes was to talk about different patterns, the CT signs suggesting ILD, the individual CTDs, and a little bit on IPAF. This is the QR code to my link tree, which links all the posts that I do on a regular basis at ctchestreview.com, ctbiopsy.com, etc. That's the book at Amazon. Thank you so much for listening to me, and have a great